With supplies of critical equipment like ventilators already running low, hospitals are forced to confront what would normally be an unthinkable decision. When you only have one ventilator, how do you decide who gets it? In some cases, that could amount to a choice of who lives and who dies. Joining me now, University of Pittsburgh Professor of Critical Care Medicine, Dr. Douglas White, and the Director of the University of Colorado Center for Bioethics and Humanities, Dr. Matthew Wynia. Gentlemen, thank you very much. Dr. Wynia, I do want to start with you. How do you make that decision about who gets a ventilator and who does not?
Well, there's been actually more thought given to this than you might imagine over the last decade or so. Dr. White has been very much involved in these conversations for many years. And there's not absolute coherence or consensus about it, but there are a few things that everyone seems to agree on. For example, you should do everything possible to avoid coming to this circumstance. Number two, if you do come to a circumstance where you have to make decisions between patients about the use of critical care resources, those decisions should not be shouldered by the team that is actually taking care of those individual patients. You really cannot ask a doctor, a nurse on the front lines to be making these kinds of ad hoc decisions. They need to be made in a systematic way by a team that is in some way sort of separated from the responsibilities at the bedside. So everyone has agreed that there really ought to be a triage team. That also allows the doctors at the bedside to really continue to serve as primary advocates for their patients. And the team, of course, the triage team, is able to see across the whole system. The last thing you would want is for some individual doctor to make a tragic choice about not giving someone a resource, and then the next day it turns out that resource was available, but it was just available a few hospitals over. So the triage team needs to have oversight and an excellent situational awareness across an area.
Yeah, to be able to deploy the resources where they're needed. Dr. White, I mean, I was a philosophy major in college, and we debate these sort of ethical decisions in my ethics class. It's one thing to do it when you're a college student debating your other colleagues or the other students. It's a totally different scenario when it's a real life scenario, obviously. And this is what doctors are suddenly confronted with in this country. We saw a draft of a memo that came out of a hospital in Detroit looking at this and making a determination about who might not be a priority for care. And they were saying people with severe heart, lung, kidney, or liver failure, terminal cancers, severe trauma, or burns. Talk to me more about that.
Yeah, first, thanks for having me. I saw that memo also. And, I think what's really important is to make a really clear distinction. That the framework that we've developed focuses on keeping eligible all patients who are normally eligible for intensive care, rather than simply excluding people because either they're very elderly or they have these chronic conditions, or some states and some medical professional guidelines actually exclude people based on their intellectual and cognitive disabilities. And so we instead took an approach where we said everyone is eligible to receive intensive care, and it's actually the availability of ventilators that drives that. So ventilators and ICU care first go to those most likely to survive the hospitalization and beyond, and then on down that list as far as possible based on the resources, not based on exclusion criteria.
Do you make a decision based on, Dr. White, about how long that person might be on a ventilator?
So with COVID-19 in particular, this is a real concern. It's not entirely clear that we're going to be able to predict how long someone will be on a ventilator. So right now, most of the guidelines don't look at that and instead say, treat everyone equally up front. And then we need to make decisions as time goes by. If people's prognosis is really poor after 4 or 5, 6 days on a ventilator, then in fact, they should probably be removed from ventilation if there are people waiting who have a much better prognosis. And that's a chilling thought. And yet the only other option means many more lives would be lost.
It's chilling and it's awful. And I hope hospitals don't have to end up making these decisions because it's unimaginable. Dr. Douglas White and Dr. Matthew Wynia, gentlemen, thank you very much. I'm sorry that our time was so short today. Still ahead, this is what need now looks like, a line of hundreds of cars